p.m. Central Standard Time. So we're going to go ahead and get started. So hello everyone, and thank you for joining us to learn more about financial risk and value-based care models. This is the second webinar of our 5-part series. The webinar today is being recorded and will be posted to our website. We will be sending the recording and the slides to the participants. We have also linked the presentation of today's webinar into the chat box. I am Shannon Sari, Program Specialist with the National Rural Health Resource Center, which is providing this webinar today. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization into the chat box so we know who is joining us today. This really helps our presenter get a good feel of the audience on the webinar. Next slide, please. Before we get started on today's webinar, I wanted to remind folks of the last 3 webinars in our value-based care series. Thursday, May 20th, 2021 is Optimizing Ambulatory Healthcare for the 21st Century with Dr. John Burrows with Burrows Healthcare Consulting Network. Thursday, May 27th is Successful Models to Engage Providers in Value-Based Care with Eric Schell from Stroudwater. And June 3rd, 2021 is Best Practices to Work with Community Partners on Population Health Initiatives with Tony Ann Richard with Healthcare Collaborative of Rural Missouri. Next slide, please. We have 2 pre-polling questions that we would like you to answer before we get started on today's session. Please pull up the first polling question. I am confident to unconfident in my understanding of mechanisms to deal with financial risk attributed to value-based care models. And then please give a couple more seconds and then close out the poll, please. So it looks like 30% are somewhat confident, 35% are neutral, 30% are somewhat unconfident, and 4% are confident. Next poll question, please. I am confident to unconfident in my understanding of key information needed to calculate financial risk attributed to value-based care models. Couple more seconds and then please close the poll. So 22% are somewhat confident, 39% are neutral, 22% are somewhat unconfident, and 17% are unconfident, Thank you for participating in today's polls. Next slide, please. In this session, participants will learn how to calculate financial risk attributed to value-based care models and hear mechanisms to deal with financial risk. It is my pleasure to introduce today's presenter, Eric Rogers with BKD. Eric is a member of BKD National Healthcare Group. He leads a team of professionals dedicated to helping clients understand and implement new revenue models, including bundled payments and accountable care organizations, He has 14 years of experience in the healthcare industry, including serving as the hospital administrator for a multi-state community health system that operated both critical access hospitals and PPS hospitals. Eric managed outpatient multi-specialty physician practices and restructured physician compensation and care delivery models, which value quality and met the demands of changing reimbursement environment. He also has significant experience in the imaging industry that includes service provision, business model education, and ownership. I will now turn it over to Eric to get us started. Eric?
I appreciate it, Shannon. Thanks for the introduction, and happy to be on the multi-series webinar on ACOs. As Shannon said, what I'm going to try to do is share a little bit of some of my experience on the provider side. The organization that I used to be a part of, we got into the ACO business back in 2013, pretty early on when it had first come out. We were in a upside-only Medicare shared savings program, and so that was really where I kind of got my first exposure to the ACO program, and we went through some similar processes to kind of model out for us, what were the risks. Obviously, back in 2013, getting into an upside-only model, the risks were fairly limited, and we were more concerned about how it would impact our fee-for-service business and impact our physicians more than anything else. But certainly, as time has gone along and Medicare has learned as well about these programs, more and more risk has been introduced. And so it really does underscore the importance and the need to think through the financial implications of participating in a value-based care model. And not just, a Medicare ACO, but if it's a bundled payment or if it's a Medicare Advantage or some other type of a commercial risk arrangement. There's lots of options that are out on the table today. So from the agenda, today, I just want to cover a couple basic things, and I'm happy to field questions. So Shannon, if you're all right with that, if people want to come off of mute and ask questions and we can have some dialogue back and forth, I'm more than happy to do that. So please feel free to interrupt or raise your hand or put a question in the chat box there. So the objective for today, just want to give a little bit of an update overview on where we're at in the value-based care space. We'll get into financial considerations that I would recommend that organizations look at and consider to make smart business decisions, not just for the organization, but also for the patients that you serve in the community and the employers in your community as well that are looking to you to be leaders in the future of healthcare. I've got a couple case studies that we can talk about. Just got some examples of two on here, but can certainly speak to others as well. Or if you're in a risk arrangement right now and you want to talk a little bit about some of the financial processes and modeling that you went through at your organization that you found beneficial or helpful, or things you wish you would have done, please feel free to share some of your thoughts on that. The third bullet point, physician implications. I'm going to talk about that more from an angle of how it impacts financials. What are our costs that are associated, and how physicians can drive performance. I'm going to leave it to Eric. Part two is another presentation that's coming up. Eric Schell from Stroudwater is going to be talking a little bit more in detail about engaging your physicians. So I'm going to let him handle the engagement with the doctors. I'll talk a little bit more on the financial impact of working with your doctors. And then last, we can talk about some strategies and still have some Q&A throughout. So with that, if we can go to the next slide, please. We'll talk about a little on the overview. First question that may be in your mind is value-based care here to stay? And that is a question that has been asked for the last 10 years 10 years, 11 years now since the ACA got signed into passage, we've been asking that question. And year after year, the programs continue to grow. It's not been a super speedy growth by any means, but it has been consistent, and it is growing in the market. Again, the initial funding that came out of the ACA was about $11 billion that came through. And of that money, a lot was spent to stand up different innovation programs. And the mechanism of CMS that is handling that is Centers for Medicare and Medicaid Innovation. There was a recent NACOS meeting that I attended back earlier in the spring. And it is a good program. If you're looking for information, particularly about ACOs, there's a lot of good thought leadership. A lot of the ACOs that I work with are members of NACOS. Good organization, a lot of info that comes out of that. But at the NACOS meeting, they had invited Liz Fowler to attend. And Liz is the new Deputy Administrator and Director of CMMI that's really in charge of all of these Medicare value-based programs. And what I did want to share to you with you today on the call is some of the comments that she made, really the tone at the top about value-based care and is it going to be sticking around. So here's a couple comments that came out of that discussion that I took some notes on. She'd said this, it's become very apparent that innovation and health system transformation is an iterative process. And you can see that in the bullet points there. You know, when I got back into the program in 2013, it was all upside and it was just ACOs. There weren't a lot of, there was no direct contracting. The next gen was just coming around. Pathways to success wasn't even a thought in anybody's minds at that time. So it is an iterative process. She said, in order for the alternative payment models to succeed, CMMI may sometimes need to speed up when there's an opportunity, but might need to slow down when a reassessment is forthcoming and the program may need some changes. And certainly we've seen some of that this year. A couple of things that have been slowed down. The direct contracting entity program has been paused. There were a lot of people that were waiting for the second cohort to open up to participate in direct contracting. About a month or so ago, CMS announced we're not going to do cohort number 2. We're going to pause where we're at, let cohort 1 run its course. So some of you may be bummed out to hear about that. There were some large convener groups around the United States that were really trying to, drum up some support and get organizations, particularly in rural areas, to participate in direct contracting. Another big one that we had a lot of discussions last year with smaller rural organizations was the CHART model, the Community Health Access and Rural Transformation ACO. And that program has been delayed at this point. So not a whole lot to update you other than there's a lot of programs out there. I think that with the change in administration, leadership at CMS and CMMI have said, let's step back for a minute. Let's take stock of each of the 60 different programs that are out there, and let's figure out where we've had good success. Personally, one of the things that I'd like to see come out of this is squeezing 60 programs down to 5. There's so many options. There's so many quality metrics, financial calculations involved with every one of these that it's tough to keep them all sorted out. I'd really like to see things come down to simplified models where more people are participating in the same ones to bring some consistency across the platform. She also said this, and I quote here, I understand that collectively these announcements may have led to questions about where the center is headed next. I want to make clear that our commitment to value-based care has never been stronger. She goes on to say, true innovation means failing until we get things right is just as important to learn from what doesn't work and be transparent about finding things that we can continue to refine and evolve. And finally, the last thing that I wanted to share from that spring NACOS meeting with Liz Fowler, she said that I wonder if we, quote from her, I wonder if we can think instead about models, the overall goal being transformation of the system rather than certification processes. And what she's speaking about there is each of those 60 plus programs had their own quality metrics and certification standards. And she said, instead of chasing all these certifications, we really need to be focused on transformation and turning organizations around. And I would echo with that comment. One of the things that I would encourage everybody that's on the call today is to think about value-based care not as a check the box type of certification. You know, maybe your board members or maybe community stakeholders are coming to you in the board and saying, well, what are we doing? Are we in an ACO? Are we in these type of arrangements? And some people just come in and say, yes, we're doing that to check the box, and there's no transformation work that occurs. Have that be your ultimate aim. So types, we've covered the ACOs, clinically integrated networks. I still see a lot of people involved in CINs out there, and they're working with their commercial or Medicare Advantage players out there, and there's better financial benefit for them to do that. A lot of it just depends on your payer mix. If you've got a healthy percentage of commercial or Medicare Advantage payers, that may be one of your better options. But like many of you in the rural areas, you may have a higher percentage of traditional Medicare fee-for-service, Medicaid, and self-pay, where a clinically integrated network just doesn't make sense from a financial risk arrangement. It's going to be more on a care management and sharing of providers from the true clinical end, not risk-taking. Bundled payments are still out there. The BPCI Advanced program is still ongoing. Medicare has paused the oncology model that's set to come out. And the main reason was ASTRO, which is the professional organization for oncology, identified that the majority of hospitals that would have been subject to the mandatory oncology bundles were in rural America. And our rural providers just weren't prepared to go from doing 30 treatments for prostate cancer down to 7 treatments. It would have been significant disruption to revenues. So that one's been paused as well. Payer considerations. I do want to move on to that and have some discussion on payer considerations for a little bit. I've taken a few notes on this, but the big things that I wanted to cover on the payer side. Any questions, actually, before we jump into that on, you know, what are my options today for value-based care? Is it Medicare? Is it managed care? What's in, what's out? Any questions from the group? All right, hearing none, we'll move on, and unless anybody wants to put a question in the box there. All right, payer considerations and margins. I do think it is important to understand that we need to identify, if we're looking at taking risk in a market, our payer mix and what the trend is with commercial and Medicare Advantage in our local market. I've seen it double over the last few years, the percentage of Medicare Advantage. So if that's the direction that your local geography is moving, you may want to spend more time evaluating options in Medicare Advantage. I will say this too, on a per person basis, the financial opportunity is greater in Medicare Advantage shared savings arrangements than in commercial. And most people kind of miss that point or haven't looked at the data that supports that. But I do want to say that again, on a per person basis, the financial opportunity is greater in Medicare Advantage shared savings arrangements than in traditional commercial arrangements. And there's a few reasons for that, but the biggest one is this. Medicare Advantage plans that exist out there are getting their money from CMS, and they get fixed amounts of money that are impacted based on the star rating of that MA plan, the HCC coding and documentation of the capture on their assigned beneficiaries, and a few other things. But those are a couple really big ones, and the spend, obviously. And so what we see happening is if you've got a 2-star Medicare Advantage plan in your network, they're getting a lot less money to care for their covered lives than a 4-star MA plan. And so the opportunity for that MA plan is to come to you as the provider in the area and your physicians, whether they're employed or independent, and say, what can we do, or what can you do, hospital and doctors, to better care for these patients and improve the outcome so that we can move from a 2-star to a 4-star and get more money from Medicare. And there's a lot of things that the providers can do. The providers can document better to capture the severity of the patient more accurately. They can prevent readmissions with more care coordination efforts. They can use less and duplicative imaging and testing procedures and unnecessary referrals where they're not needed. So there's a lot of things that can be done on the fee-for-service side, but at the end of the day, it just means more money for the Medicare Advantage plan. So that's where the rubber meets the road to say, how can our efforts at the hospital and with our clinicians that impact how much money you get, how do we share in that savings? And that's where the better traction comes with these risk arrangements, is that if you help them improve their star ratings, you should get a piece of that savings, a piece of that premium. Also, the dollar amount spend for these Medicare Advantage plans is quite a bit different in the two. And there's a better opportunity for you to share in the MA plans. So I did want to talk about that, is that you make your margins as a hospital off of your commercial business and your MA business in your organization. Now, collectively, that may only be 20, 30, 40% of your total revenues in your activity, but that's where your margins are coming from. And so thinking about if there's more money in the pool, in the pot over there, that's where we may want to be thinking about an opportunity for us to share in that because of our efforts. So I just wanted you to be aware of that and how the premiums and the medical expenses are calculated across those. You know, it's not a new term, but a lot of organizations, one of their strategic goals for the hospital is we want to become Medicare break even. I don't know how many others, that may be part of your strategic plan, or maybe your CFO at the hospital really thinks about how do we become break even for Medicare, where we lose quite a bit on our Medicaid and or our self-pay. We'll break even for Medicare in the middle, and then we subsidize with our commercial business. So if we can at least get break even in our Medicare, we think that we can make a bottom line, or at least break even is an organization in the aggregate. I think that's a good goal, but how that's played out and how that's realized can be challenging. But I do see that as a good way to think about solving part of this problem. Let's move on to our next slide here and start to get into some of the meat and the potatoes on the financial considerations. So if we're not just a check the box organization and we're going to get in, your runway for upside only risk is going to be pretty short. If you're not in a program now and you get into most likely the Pathways to Success basic track. So there's a basic track up here and there's an enhanced track down here. The basic track has multiple levels, A, B, C, D, and E. And track A is the only one where you can be in upside only, and that's a a very short window. You're going to get pushed from A to B, and then B to C, D, and E on down the line. And so there is going to be risk that you're going to need to take into consideration. So organizations, have a number of ways that they try to estimate the financial impact of projecting performance. One way organizations do that is to build in assumptions that are based on the results of similar organizations, what they've been able to accomplish. The good news is on the Medicare side, all of that is publicly available. I would encourage you to go out and look at the 2019 and 2020 ACO results. It's shared publicly from CMS, and you can go out there and see all of the ACOs that are out there, who are the winners and who are the losers. And a good way to kind of find a benchmark for yourself is to look up the number of covered lives. How many beneficiaries are signed up? If you're a small organization, don't benchmark yourself with an ACO that has 60,000 covered lives. You may only have 5,000, or you may only bring 500 into an ACO as a participant, and the larger ACO group has 8,000. So really need to be looking at the smaller ACOs that are out there and looking at their performance. There's still a lot of them that aren't making or losing money. The predominance is still net neutral. So you can go out and look at those historic trends to estimate it. Another way is to assume that your organization will achieve a certain actuarial benchmark. So for example, a hospital can calculate that the commercial pay per performance bonus on the MA side that you'll earn if you move from the 50th percent nationwide to the 75th percentile in avoiding readmissions. And we can come through a process and look at, okay, what is reducing readmissions from, 6% down to 3% due to our organization's fee-for-service business? And what does it do to our likelihood of achieving shared savings in the ACO? Start to getting into more of those fine-tuning opportunities. The sensitivity analysis that I've got there, there's a range of high and low. One of the things that I do want to bring out is if you've been in the traditional shared savings program, you're going to be accustomed to a minimum savings and loss threshold. And you had the ability to choose a lot of those shared savings and losses. So for example, as an organization, if your benchmark is $10 million, so let's say that was calculated based on, we've got 1,000 covered lives and our aggregate target price of $9,000 per beneficiary times 1,000. Let's say it's $1 million, just for sake of discussion. That is our aggregate benchmark. Organizations could come in and think about their minimum savings and loss threshold and say, I'm going to set it at 2%. And so unless I save Medicare 2%, I don't get any savings myself. Or unless I lose Medicare and go over the spending by 2%, I don't have to pay anything back. And we saw a number of organizations get into ACOs where they set those thresholds really high because they were afraid of having to pay back some money. And so they said, we're going to go 2.5%. We don't think that there's any way that across our covered lives that Medicare would spend 2.5% more fee-for-service money, and so we're safe. But what happens is, if you go to that extreme on the overage, you're never going to get a shared savings. So you can always tell how much providers are willing to take on risk by how tight they set that gap. In the Pathways to Success program, I mentioned in the basic tractors A, B, C, D, and E. One of the things you need to consider is that in track A and B, you're going to get a first dollar savings rate of 40%. and that just cannot exceed 10% of the benchmark. So for example, we talked about $1 million being your benchmark. You couldn't lose more or save more than 10% of that benchmark. And we're going here at first dollar. So there's no minimum savings and loss threshold. So if you save Medicare $1,000, you're going to get 40% of that $1,000, which is great, all the way up to 10% of the benchmark. Good deal. Tracks A and B, years 1 and 2, it's all upside, no downside. So you can build that into your financial calculations very easily by simply looking at how many Medicare covered lives are we going to bring to the program. Now, track C is where downside risk comes into play. Again, you're going to have first dollar opportunity at the savings, but instead of 40% of that first dollar, you're going to get 50%. So the opportunity goes up a little bit, but on the downside, you're going to have to pay back 30% on the first dollar of your losses. So again, in your track C or your third year of the program, you're going to get 50% on the upside at first dollar, but you would have to pay back 30% on the downside. And again, top side, you can't exceed more than 10% of the benchmark. On the bottom side, they're going to cap your losses at 2%. So you can see right away, Medicare is still wanting to encourage your participation by saying, at the very worst, if you totally blow it and you go out of control on spending, I'm going to cap you at 10% of your benchmark on the upside, which is good, but you're only going to have to pay back 2% on the losses of your benchmark. So that's track A, B, C. Now D, it stays at 50% first dollar and 10% of the benchmark. But on the downside, it gets a little tougher. You're going to have to pay back 30% again, but now instead of 2% cap, it's 4%. And then in your final year of the program in track E, you're all the way up to having to pay back 8% of your total benchmark, and it's $30% of your first dollar. So I know I covered a lot of numbers there. There's tables that are out there from Medicare, but that's the easiest way to start looking at my upside and downside losses on the extremes. What's the most I could lose? What is the most I could win and get in shared savings from my program? Now, that is if you as a sole hospital or hospital and physicians that are a part of that get into an ACO on your own. There's not a lot of small hospitals that are getting in on their own these days. You just don't have enough covered lives. And there's just a lot of things to do. It's a big lift to stand this up on your own. And so traditionally what we see is hospitals get involved with other organizations, other hospitals, and they form their own ACO entity. Or there's national conveners or conveners in your local state that can help you navigate the process, help share some of that financial burden for your organization, and give you IT resources or practices for care management infrastructure. I see we've got Marshall Browning on the call. There's several people from Marshall Browning. We did go through a process with Marshall Browning to look at, does a value-based care arrangement make sense for our ACO? And there was a great opportunity we looked at for them is in their state, they had a statewide consortium that pooled together a lot of critical access hospitals in their state to coordinate ACOs. And I think it was a good option for them to look at. I'd be curious to kind of hear if they've got some comments as well, how things are going and where they're at. But those are often the arrangements that we see with our smaller hospitals, is that they're working with a convener. Caravan is another convener that's been out there for a number of years. We've done some financial modeling for them in the past as well, but those options exist out there. That may be as I'm talking here. If you want to make a comment in your chat, if you're a part of an ACO, can you just let us know and say, yep, we're in one and we're doing it on our own, or we're working with a third party? And maybe that would be helpful to put in the comment space there. So looking at volume, I don't have my screen shared here, but what I'm looking at here is a financial analysis we did for an ACO that has 36,000 covered lives. They've been in the ACO, this is their third year. And I'm kind of looking back at my notes here of when the board and the C-suite had reached out to us, going through a process to do financial modeling. What were some of the key things that we looked at for assumptions in the financial projections? The first is looking at who are all the participants. And so your participation is based on your tax ID. And so it's very important to know, hey, if my organization is not going to do this on my own, and we're going to work with a larger group, a larger hospital, or a convener entity, they're going to use our tax ID to trigger the participation arrangement. And so while there may be risk at the top level with that group, that's one thing to consider in your financial projections is if I sign a contract to be in their ACO, how much downside risk do they pass on to me according to my tax ID number? So if I'm bringing 1,000 covered lives and my performance is really good, we hit it out of the park, and for the 1,000 covered lives that we bring to the ACO, we reduced spending, we had high quality, but there's 5 other people that are participating in that ACO, and 2 of them are a train wreck. They can blow all the shared savings for the whole ACO, myself included. And so you really need to look through your contract with the ACO to understand how the performance of others may impact you. So they should have language in there that very clearly states that. So go to that contract and look at how the distribution works. You also need to understand that most likely if you're in with a larger group, if there are shared savings, the first dollar of that shared savings to the ACO, they're probably going to use to pay off their own costs. So if they've got IT resources, if they've got people, if they've got marketing, development, staff, they may cut in and take 50% of the shared savings from Medicare right off the top. And then the other 50% gets distributed to the members of the ACO based on how many participants they had, covered lives, sorry, and the quality. Quality has to be baked into that. So by the time that costs off the top are paid for and there's residuals that come to you, it may not be a whole lot of money. Don't get into an ACO to make money. I'm just going to tell you that right away. Don't get in these programs to make money. Get in these programs to transform your organization and continue to prepare yourself for moving forward into risk-based care. So some other things that we looked at in the financial modeling. Number one, key thing after you look at the contract is how many covered lives am I going to contribute to the ACO? And we know that methodology of attribution is based off of the predominance of E&M encounters. So your 9921s of established patients, you need to get the predominance of those. Organizations never have as many traditional fee-for-service Medicare attributed lives as what they think they do. If you think you've got 100, most likely you've got about 50 or 60. That's about the percentage we see come in real life when we reconcile the Medicare rolls and attribution with what you think you might have. So it's quite a bit lower. So look at your attributed lives, number one. Other things that you need to take into consideration when thinking about your financials. If you're in a CPC Plus program, I know that those programs have changed a lot over the years, but there's still some implications that you need to take into consideration. You may lose some of your CPC Plus benefits by being in a Medicare ACO program due to some of the overlaps. You might be able to make up, though, with the MACRA and the APM 5% bonus. Your providers will automatically be included as an advanced alternative APM provider, and they're going to get that 5% bump on their professional fee-for-service monies. And that can be pretty good. For example, that ACO that we worked with starting, that's still going on, they had about, again, 36,000 Medicare lives. Their APM bonus was close to $11 million is what they got for all of their providers being in the APM. And it also alleviated some of the burden of all the quality reporting that they would have had to have done. So it's not negligible. It is something to keep in mind. So attributed lives, impact of some of your existing programs, if you've been in PACE or CPC Plus, things like that need to be taken into consideration. And then you have to look at factoring in those first dollar savings and loss percentages that I recapped for the pathways to success. The 40% first dollar, 50%, and then the downside of 30% on the losses. So those all have to be taken in. Here's where it gets tough. In addition to the expenses I've got listed there, we also need to understand if I get into a value-based arrangement, being successful means that I have cut fee-for-service revenues. Now, ideally, it means that we've cut other people's fee-for-service revenues. Maybe it's a skilled nursing facility that's in the community that has historically had bad quality outcomes and lots of readmissions, and they've kept their Medicare patients way too long just because they could make more money on them. Ideally, you want to cut other people's unnecessary fee-for-service revenues, but a lot of times it may mean that it's cutting in on your fee-for-service business as well. So CFOs get really nervous when we start having these conversations about value-based care, because success in this camp means fee-for-service losses. You cannot flip the switch and move from fee-for-service to value-based overnight. It's a process. It's a transition. You've got to make it with eyes wide open. We still have to have a bottom line, and we still have to make payroll for our organization from our fee-for-service revenues. Inpatient stays would be going down in an ACO if it's effective. The ED would go down, utilization, and a big one for our critical access hospitals that are getting cost reimbursed for their swing bed days. Every day in the swing bed, you may be making $1,500 to $2,200 a day for your Medicare fee-for-service patients in the swing bed program. That's a lot of money that would make an ACO a loser on that end if you had an aggressive swing bed program on your Medicare patients. So it's a dichotomy that's got to be looked at. And if your swing bed program is a part of your bottom line and it's important to it, we're going to have to think through how that works or doesn't work for the organization. I know that's a tough thing to say, but we've got to live in reality on some of those. Imaging is another one. You know, MRIs and CTs, they're not cheap. And a lot of times it's good revenue for the organization, but could an X-ray have done when that CT was ordered? So we got to think about the impact of fee-for-service revenues. Any questions on those? All right, I do want to talk about the expenses for just a minute before we leave this slide. I didn't cover those in detail. In addition to cutting fee-for-service revenues, the expenses can go up. I've seen organizations spend millions of dollars, bigger organizations spend millions of dollars in the ACO business and come away with no shared savings. And a lot of times the expenses are coming from staffing and EHR or population health software, tools, bolts-ons, things like that. we've got this grand idea that if we go out there and we purchase Healthy Intent or Community Works or health and, whatever the name is, fill in the blank of your desired pop health vendor, that if we buy that, that's going to help us be successful. And it's not the IT program that drives the change. It's the people, it's the culture, and it's the processes. It can be a tool and help you get there, but it's not the silver bullet. I'll just tell you now, and it's an expensive one. And it may not interface, I guarantee you, it will not interface as promised by the sales team that's trying to sell you that tool. So just be careful with the IT. I would say start off, use what you've got. Use Meditech, use CPSI, use Aprima or your other systems to find out what capabilities they have. Stay focused on the basics, on keeping people out of readmissions and other key areas where they're using excessive post-acute care. You don't need a fancy EHR bolt-on to tell you how to do that. The other one is staffing. Some organizations think we've got to go out and hire an ACO executive director and pay them, 6 figures. That's not always necessary. I realize you're probably already spread super thin, and if you just say, the chief nursing officer or the director that's over our clinic operations, we'll just add that to their role. They may be able to handle that, but they may not have enough time in the day to get that done. So thinking through, do we need to hire somebody to oversee our value-based care efforts? It may make sense. I will tell you that they've got to think about multiple avenues outside of just the value-based care. A good thing to also consider to offset staff and salary expenses is going to be how that programming could help you potentially achieve bonus payments in your existing arrangements. Go out and look at your current contracts with Blue Cross Blue Shield, Anthem, Coventry, and see, are there provisions in our existing contracts with commercial and MA to improve quality? And if we do that, we get a 4% bump in our contract. Use your infrastructure for value-based care to drive those payments, and maybe that'll offset or even cover the cost of additional staffing or additional responsibilities. So chase those performance incentives on the other side of the coin. Participant fees. This is another one that it's a mixed bag. Some organizations will charge you to be a participant in their ACO. So really understand and know what you're getting. They're probably going to say, well, you'll have access to our analytics and reporting tools. Ask for copies and examples of what kind of reporting they're going to give you. Are they going to have an IT system that your providers can log into during point of care to document and capture HCC? So really understand what you're going to get from what you would have to pay. But there are still a lot of others out there that don't charge you to join the ACO. Both are out there on your expenses. All right, next slide.
And Eric, my apologies for interrupting. I just want to remind you that we have about 12 minutes left. Thank you.
I'll speed up. You bet. So here's a case study, a good example. This is kind of the standard format, if you haven't seen it, what comes out from Medicare on how they say, did you make or lose money or break even this year in the ACO? This is, if you're in one, this is exactly what the ACO entity will receive. If you're a participant under that ACO entity, ask for a copy of this report. You'll see how many total lives were assigned. This particular ACO had 33,000 Medicare lives. They'll calculate, so some people may leave during the year or drop off the rolls. So you'll see it calculated in person years, kind of like member months. You'll see how much is spent in the different categories of end-stage renal disease, disabled, aged, and non. And then you see all of the calculations that Medicare goes through to determine, do we receive a shared savings or not? So this particular organization, they saved Medicare $1.6 million compared to the target price. And their savings and loss threshold was set at 1%. You remember I talked about that earlier. So this said that they would have had to have saved Medicare $3.7 million to be in the savings bucket, and likewise would have had to have been over 3.7 to be in the loss. So they didn't meet that threshold requirement. Quality score was good. They were at 94%, and they would have had a 47% of the shared savings of everything above 3.7, but they were 2 million short that year. So they didn't get a shared savings in that particular year because they didn't quite get to the 2% or the 1% threshold of 3.7 million. Next slide, please. All right. Expenditures report. I won't go over all of this, but this is a detailed utilization report that the ACO will receive. These are good metrics to keep a disciplined eye on in understanding financial risk, looking at short-term stays, long-term, rehab, hospital. And the reason I gave this to you is that it shows for this particular ACO what their results were. And then it says all ACOs across the United States, what's the average? So this is a good place to kind of benchmark yourselves to say, where should we be to be able to benchmark ourselves? Next slide. So here's a good example of a reconciliation. So how does Medicare come up with the fact that we were 1% over the target price? What all goes into that calculation? And it is a bit of a black box, but there are some things that are known. So for example, the HCC impact, we know that our coding and documentation can move the benchmark up or down. I'm going to give you an example. This is probably not the best way to do this, but I'm going to hold up a graphic here. Hopefully you can see a little bit. This is a histogram of changes to the benchmark price. And what I want you to note is that everybody was grouped in that bell curve between about 0% change and 6% change. Most people fell in that area. And so the benchmark would go up between 0 and 6% for the predominance of providers. So if we were to come in, I mean, just at a high level actuarially and say, okay, on a high end, we think that we could be as much as a 6% bump in the benchmark, and the low end 0. If we just take the statistical median of that, let's say 3%. So if I had $1 million aggregate benchmark, I want to inflate that 3%, and that's what Medicare is going to give me for this year of an inflationary factor. We've got to understand runout of claims paid, IBNR, how many lives that get adjusted as well based on our member months. So you can see they had a benchmark of 11,600. And with the 1% increase, they calculated what they predicted it might be. So I give this to you as these are some of the basic mechanics that you need to know in estimating a financial settlement. This minimum savings and loss threshold, this won't be an implication in pathways to success, but you can put on here, maximum savings and loss thresholds that are in the Pathways program. Next slide. Case study 2. This is an ACO that had 15,000 covered lives. They had some people leave throughout the year, so their person years came down a little bit. But what I want you to notice, I thought was interesting on this, the percentage of their Medicare patients that were disabled and dual eligible. 41% of their patients were disabled. 26% of their patients were Medicare and Medicaid dual eligible. Really high. And what I want to tell you about this is actually an FQHC. It's a combination of about eight or 10 FQHCs that are in an ACO. And at the bottom, it's hard to see, it's a bit cut off, but their savings that year were $2.5 million. So what I'm going to tell you is strategically, people have shied away from patients that are disabled, end-stage renal disease, and dual eligible. There's a recipe out there that works, and I've seen organizations get really good at caring for these patients and hitting it out of the park. Next slide. Physician implications. Really the one thing I'm going to say here is, if doctors feel like their hard work in documentation, coding, and everything else that they're having to do results in one of these, like, what's in it for me? What's my share? You need to be prepared for those conversations. The clinicians, in a sense, hold the keys to performance. And if money is spent by Medicare, so it's a challenging thing to think of, but you do need to consider that. And I know Eric Shell's going to do a great job kind of talking more in depth about this in the next presentation. All right, next slide. Q&A. All right. So we've just got about 4 minutes. What I would like to do is open it up. If we've got people that want to come off and ask a question, happy to ask a question here at the end of the call. Or if you want to shoot me an email, you want more in depth, happy to do that as well. So I'm going to leave it open here. Feel free to fire away at me.
Thank you, Eric, so much. While we wait for folks to put stuff in the chat box, Patricia, could you go to the next slide, please? We'd like to take just a few moments to pull up our post-polling questions. And during that time, if you have a question for Eric or a comment, please put that in the chat field. But Patricia, please pull up that first polling question. I am confident to unconfident in my understanding of mechanisms to deal with financial risk attributed to value-based care models. If you could give just a few more seconds and close that poll, please. So it looks like 17% are confident, 56% are somewhat confident, 17% are neutral, and 11% are somewhat unconfident. Thank you. Please pull up the second polling question. I am confident to unconfident in my understanding of key information needed to calculate financial risk attributed to value-based care models. Please just give a couple more seconds here. So 5% are confident, 50% are somewhat confident, 25% are neutral, and 20% are somewhat unconfident. Last polling question, please. I am confident to unconfident that I will apply the knowledge gained from this educational training to assume risk and participate or continue to participate in value-based payment models to prepare for population health. Please just give a couple more seconds. So it looks like 20% are confident, 40% are somewhat confident, 30% are neutral, and 10% are somewhat unconfident. Thank you for participating in the polls. Once again, today's presentation is in the chat box. The recording and presentation will be available after our value-based care webinar series. And next slide, please. And Eric, so far I haven't seen anything come through the chat box. But once again, we do encourage you to join us for the remaining value-based care webinar series, which resumes on May 20th. The webinar will focus on optimizing ambulatory healthcare for the 21st century with Dr. John Burrows at 11 a.m. Central Standard Time. Next slide, please. So it looks like it is noon, but like Eric mentioned, if you have questions or comments, please feel free to reach out to us or reach out to Eric. Once again, thank you, Eric, for your time today. Also, thanks to all the Delta program participants for joining us. I hope you found this session beneficial. And as always, please don't hesitate to reach out to us at the center with any additional questions. I hope everybody has a great day.